Hello, everybody. My name is Fabien Arous. I am one of the new primary care sports medicine physician with Children's Health at the Andrews Institute. We actually just opened the new location in Prosper, and we're excited to see new patients over there. I originally come from France. I trained there. I did my residency over there, and then I came here and did an additional internal medicine residency, followed by a primary care sports medicine fellowship at the Andrews Institute in Pensacola. And I'm excited today to talk to you guys about sports medicine, general medicine. So basically what we're going to focus about is talk about kind of joint pain in general, but focused a little more about differential diagnosis. Obviously we'll touch base a little bit on osteoarthritis, but it's mostly to kind of think about all the other diagnoses and how to approach joint pain. I don't have any disclosure to this talk. So here's the topic: approach to joint pain and differential diagnosis. The objectives are to discuss important information together when approaching joint pain, review the differential diagnosis and etiology of joint pain, and review of inflammatory versus non-inflammatory joint pain and monoarthritis versus polyarthritis. So just a quick slide. Osteoarthritis in general in the United States, it's very common. Lifetime risk of developing knee OA is 40% in men, 47% in women. 92.1 million have diagnosed arthritis in their patient or have symptoms consistent of arthritis. Between 18 and 64 years old, 1 in 3 persons have a diagnosis of arthritis. When we look at patients above 65 years old, 1 in 2 men have arthritis and 2 in 3 women have arthritis. So when we have patients with arthritis, it's always still, good to keep in mind that those comes with additional potential diseases, and we just have to treat them like any other patient and talk about looking for other potential disease, whether it's heart disease. 1 in 4 adults have a heart disease. Close to 20% have chronic respiratory conditions, 16% have diabetes, 18% have major depression. So we always keep a wide approach on those patients and just screen them with all the other diseases that we screen on our regular patients. So I'm going to start this presentation with a vignette. This is a 55-year-old female with a past medical history of coronary artery disease, hypertension, diabetes type 2, gout. She had a DVT on the right leg 2 months ago. She has chronic low back pain and psoriasis, and she presented to the sports medicine clinic for 2 months of worsening right knee pain. She was referred by her primary care. The pain is constant. She said it is worse in the afternoon after prolonged walking. She has bilateral intermittent swelling, but the right is worse than the left. She also noticed some deformation in her hands over the last couple of years. She denies any recent trauma. She denies any fever, chills, skin changes. She recently moved from Maine. She has been feeling fatigue with headaches for the past month and was started on levofloxacin for sinus infection. She has a family history of rheumatoid arthritis in her sister, and both parents have severe hand and hip OA. She takes medications. She takes Xarelto, aspirin, lisinopril, carvedilol, hydrochlorothiazide, atorvastatin, and metformin. So not an uncommon patient, coming from internal medicine, especially in the hospital or primary care setting. I think we've all seen this type of patient. They show up in the clinic quite often. And this basically make the differential diagnosis very wide when we look at that. So that's her x-rays. We can see that she has a little bit of tibial spine spiking, and then she has a little bit of narrowing of the medial joint line. So she probably has some degree of arthritis, but it's not severe. It's probably mild to moderate. So what are the different differential diagnoses? So as you can imagine, the list is going to be very wide. If you keep in mind that vignette, could it be arthritis? Sure. She has the age. She has the x-ray. Psoriatic arthritis. Yes, we said that she has a past medical history of psoriatic arthritis. Could it be gout, flare, or pseudo gout? She has a past medical history of gout. So could that be a flare? Could it be a levofloxacin side effect? She was taking that medication for sinus infection, rheumatoid arthritis. She has some deformation here in her hand, so something to keep in mind. Lyme arthropathy, she comes from Maine. This is the main region in the US, in the main state in the United States with Lyme disease, so something to consider. Hemoarthrosis, we said she was taking anti-vitamin K medication for recent DVT, so also in the differential spondyloarthropathy, she has some chronic low back pain, septic arthritis. That's something to think about each time we have knee pain, joint pain in general. Viral arthritis is also common, so something to think about. Lupus, always in the differential diagnosis, especially when we have a personal history or family history of autoimmune disease. Endocrine disorder, always a possibility. Where did that one go? Reactive arthritis, we'll talk about this a little later. Always a possibility as well. Sarcoidosis, fibromyalgia, systemic vasculitis, malignancy. So differential diagnosis is very wide, and we'll try to find ways to kind of narrow those down based on the history of the joint pain, and based on the personalized approach, based on family history, personal history, medications, and all that. So what to do next? So this can be overwhelming. The response is often, you should talk to your primary care, or we're going to refer you to rheumatology. So hopefully, those are still great options, but hopefully coming out of this presentation, we'll have a better idea of what to order next, or what test to order, what question to ask. So how to classify joint pain in general? Those are kind of like the big 5 groups. I like to think about this in my head when I actually see someone in clinic. I think the first one to think is actually infectious arthritis here, because we always have, those are kind of the bad one. We always have to think about, is it a septic arthritis? So is it bacterial, is it viral? Then I always think about all the autoimmune tissue disorders. So rheumatoid arthritis, systemic lupus, so lupus, vasculitis, where we talk about polymyalgia rheumatica or polyarthritis nodosa. There are others, obviously, Sjogren disease, sarcoidosis. Then we have the big group of spondyloarthritis. Those include ankylosing spondylitis, psoriatic arthritis, reactive arthritis, inflammatory bowel disease. Crystal arthritis, always important to think about those are common. Those include 3 big group of crystal arthritis. We have gout, which is the most common one. Pseudogout, which we'll talk about later, is usually with chondrocalcinosis, and then hydroxyapatite crystal deposition disease, which is a third crystal arthritis. And then others are going to be arthritis, fibromyalgia, amyloidosis, and malignancy. So that helps me to kind of, when I approach joint pain. So hopefully that can help you guys as well. So what information to gather when we see those type of patients? So as we talked about earlier, we have to get information regarding the joint pain itself, but also personal information that's going to help us kind of narrow down our differential diagnosis. The first one we're going to talk about is the chronology of symptoms. So if the pain happens suddenly within minutes or seconds, usually it's kind of obvious. So this could be a trauma, a fracture, internal derangement, or loose body. And then obviously we have to get an X-ray, or sometimes an MRI. But obviously chronology is always a very important information to ask. If the pain happened within several hours to a couple of days, this could be an infection. This could be gout. Gout tend to happen fairly quickly. And that also could be an inflammatory arthritic condition, a flare or a new onset. And then if we have insidious onset of pain over days to weeks, that could be an indolent infection. Those infections that have been there, but they slowly grow and they can take much longer to develop. Arthritis, osteoarthritis in general, is usually not acute. It usually takes a couple of days, and usually patients said that it progressively worsens over a few days or weeks. Obviously, if it's a tumor or an infiltrative disease that also not acute, is usually more of a progressive pain. So we also have to ask and talk about, is this monoarthritis or polyarthritis? So monoarthritis means it's one joint only, meaning it's just going to be the right knee or the left knee or the right elbow. When we talk about oligoarthritis, we're talking about 2 to 4 joints. And polyarthritis are usually going to be several joints. So people coming with several joint in the hands that are painful, also bilateral knee pain, bilateral ankle. So it's much more wide. It's always important when we have, whether it's motor arthritis, polyarthritis, it's always important to differentiate inflammatory versus non-inflammatory disease. And those are going to be visible on exam as well as in the history. So the questions and the exam to do is, if it's an inflammatory disease, we always have joint swelling. It's usually pretty red, as we can see on this picture. There is erythema. It's usually warm to touch, and it's usually pretty painful. Patient usually said that they have some prolonged stiffness, usually more than an hour when they wake up in the morning. And usually the pain is symmetric. So it's not uncommon to have bilateral knee or bilateral hand inflammatory joint problems. Those are usually suggestive of inflammatory conditions. We'll review those a little later. That could be RA, that could be lupus, that could be other more unusual diseases. When we talk about non-inflammatory process, those are usually degenerative. The sweating is not always there. You don't always have erythema. The morning stiffness can be there, but usually doesn't last more than an hour, usually less. It's also usually asymmetric, and those are subjective of non-inflammatory conditions. I always think it's very important to look at the hands and the feet of the patient. Those can give a lot of information about the diagnosis itself. For example, here, if we talk about rheumatoid arthritis, here at the bottom, we have next one deformity. So that's a hyperextension of the PIP, and it's hyperextension of PIP and hyperflexion and a flexion of the DIP. This is called next one deformity. This is pretty pathognomonic, pretty common with rheumatoid arthritis. That one on the right is a boutonniere deformity, where we also have the MCP that is flex with an IP joint that is hyperextended. And the ulnar deviation, I think that's probably one of the most common one, where we have all the MCP that are swollen and they actually deviated towards the ulnar side. Psoriatic arthritis can also be seen in the hands and the feet. Here on that left picture, we can see that there is nail pitting. This is in favor of psoriasis. So it doesn't mean that every patient with psoriasis are going to have psoriatic arthritis. However, if we have somebody complaining of joint pain and is having those nail changes, that's definitely something to consider. That bottom picture with a picture of the feet, here we can see that the fourth toe is very swollen. We call this sausage finger or dactylitis. This is definitely a flare, probably coming from psoriatic arthritis. This is pretty pathognomonic of that disease. And we can also see here nail pitting as well in that picture. Other things that we can find when we look at hands and feet, gout. So I think people know about this. That's called a tophus. When we have several, it's called tophi. This is a deposit of urate. So this is a urate crystal deposit. Those can be painful or not. And they can come pretty much in any joint, but that's how they look like. They're usually kind of like that white looking bump. Osteoarthritis, we also have deformity in the fingers. It could be PIP. When it's PIP, those are called Bouchard deformity. When it's the DIP, those are called Heberdin deformity. Those are not like gout. They don't have that white deposit. Those are coming from bony change and capsule changes, and we can usually see changes on X-ray as well. So yeah, so that was an important thing to talk about: motor arthritis, polyarthritis, looking at the hand, looking at the feet, getting a good history on the swelling, the redness, the type of pain, if there is also stiffness in the morning or not. Looking for symmetry of the joint involvement is important. As we talked about a little bit earlier, if it's symmetric, usually we think about rheumatoid arthritis, lupus, polymyalgia rheumatica, viral arthritis. Polymyalgia rheumatica is actually pretty common. I mean, not pretty common, but it's pretty easily to miss it. It's usually people complaining of bilateral shoulder pain, bilateral hip pain, usually in the 50s, 60s. And that can sometimes be misdiagnosed. They respond really well with a small dose of prednisone. And that normally they also have an abnormal blood test with ESR that can be elevated. Viral arthritis can also cause symmetric joint involvement. Those are also very tricky. They can last for a little bit of time. I don't think I've seen that many, but you know, it's everywhere. It's written everywhere. It's a known thing, so that's something to think about as well. Asymmetric joint involvement, psoriatic arthritis, reactive arthritis, ankylosing spondylitis, gout. So those, yes, so those are going to affect one, maybe several, but they are very rarely symmetric. Just a quick slide on viral arthritis. This is usually an acute onset polyarticular arthritis, which is the most common presentation of viral arthritis. Whenever we have parvovirus, hepatitis B, C, EBV, or tropical viruses such as Zika, chikungunya, or HIV, that can be a pretty common presentation. The treatment for those are usually NSAID or acetaminophen. Some people use steroid, but probably not the right thing to do and not recommended anymore. And then obviously treat the cause. And if it's HIV or such diseases, we have to start antiretroviral medications. Distribution of the affected joint is very important as well. So those are the three things to think about. So what is the pattern? Which joint do they affect? So if somebody comes with small joints, that could be lupus. If it's coming from the large joints, ankylosing spondylitis. If it's both, that could be RA or psoriatic arthritis or osteoarthritis. For RA, for example, those affect the MCP and the PIP. They almost never affect the DIP. OA, on the other side, they affect almost very commonly PIP and DIP, almost never the MCPs. And if we have Lyme disease, those spare the hands. So I just like to, I've learned those over the years, and it's helpful if you have severe DIP changes. Well, that can actually help your differential diagnosis. Lupus, if you have terrible knee pain, unlikely to be lupus. Those are usually smaller joints. And ankylosing spondylitis, we all know this is low back pain, but that can also usually affect the large joints, so knees, elbows, less commonly hands and feet. Looking for osteoaxial involvement can help. RA, for example, can involve the spine, usually C1, C2. Ankylosing spondylitis will affect usually the low back, the lumbar portion of the spine. And lupus would usually not affect the axial involvement. So there's usually no back pain, no back problems in lupus. Obviously, they could have additional problems that cause back pain, but it's usually more peripheral joints. Looking for enthesitis is important, plantar fasciitis, Achilles tendinitis. That can also happen specifically for the spondyloarthropathies. So that distribution of pain is also important. Next thing to think about is I always ask about extraarticular manifestation. Here are some fairly common extraarticular manifestations. Those can either be a rash, obviously psoriasis. Here at the bottom here, we have probably something like discoid lupus. Lupus itself can cause rash, just like this one here at the top. So always ask for skin rashes, or important to take a look at it. Oral and genital ulceration, that could be coming from Behçet's, coming from Crohn's disease. So always asking for repetitive ulcers can be an important findings. Renal phenomenon, you can see here on that picture, that's the renal phenomenon that can be seen in lupus or scleroderma. Serositis with pleurisy or pericarditis can happen in lupus. Zika symptoms, which is basically dry eyes, dry mouth, can happen in lupus and Sjogren's disease. Eye inflammation is usually uveitis, anterior uveitis. It can be happening in lupus and RA. And bowel inflammation, Crohn's disease, ulcerative colitis. So always important to ask, have you had any change in your bowel movement, whether it's usually more, that can give us a clue. And neurologic symptoms is also important to be aware of. I just wanted to quickly talk about hemochromatosis. This is an abnormal accumulation of iron in parenchymal organs leading to organ toxicity. This is the most common autosomal recessive genetic disorder. 75% are asymptomatic. And the early symptoms include severe fatigue, which is probably the most common one, impotence, and about half of them have arthralgia. The most common signs are usually hepatomegaly, skin pigmentation, and arthritis. That's why I wanted to kind of plug this in that presentation. It's it's not common disease, but we see those, and they tend to have joint pain. They also have liver disease. They have hyperpigmentation, like we talked about. They can also have diabetes, joint pain, like we talked about, amenorrhea, impotence, hypogonadism, and cardiomyopathy. The typical finding on labs is having a transferrin saturation values more than 45%, which is considered too high. So we can order that lab value when we think about hemochromatosis. The typical finding on X-ray, and this is pretty pathognomonic if we have the story plus those X-ray finding, is chondrocalcinosis. We can see those at the knees and the wrist. The typical finding is the hook-like osteophyte at the MCP. So we can find here they have like those spurs coming from here, the third and the fourth MCP. They could be anywhere. And this is the chondrocalcinosis. They are pretty common in the TFCC and or the lunotriquetral ligaments right here. So that's those deposits that can be seen in hemochromatosis. So regarding the joint pain, so we talked about chronology, we talked about motor arthritis, polyarthritis, we talked about joint involvement, the symmetry or not, we talked about distribution, we talked about extraarticular manifestation. Obviously, always asking about fever. I didn't do a special slides on this, but if we have fever, chills, much more common to have septic arthritis. So it's an important question to ask. So that's about it regarding the joint pain itself. And now it's always important to obviously ask questions about personal information. The first one is always history of trauma. Obviously, if there was a recent trauma, that changes the diagnosis. So, very commonly we have people coming for joint pain, let's say right knee pain. First thing I usually ask is, have you had a trauma? And then, oh yeah, had a trauma a month and a half ago, and they kind of forget about it. But then by talking a little more, we can see that it's related. So always important to be aware of a trauma or not. List of medication, very, very important. Those are the medications that commonly can cause joint pain. Levofloxacin, it's a quinolone medication. About 25% of the time, they can cause pretty bad joint pain. Statin medication, I think we've all, heard of that for hyperlipidemia, hypercholesterol. 10% of people, and I think probably more, have some kind of muscle pain or joint pain. They usually have a hard time, describing it. It's usually some weird body pain, but those statin can cause joint pain. Risedronate, this is a biphosphonate given for osteoporosis, usually then can definitely cause joint pain, and it can be disabling actually, and sometimes we have to change the medication for that. Fluticasone inhaler, I would say not the most common I have seen, but this is a medication that's commonly used. It's reported that 20% in 20% of the case, this can cause some kind of joint pain. I don't know if much of us actually look for these, but important to keep in mind. Anastrozole, letrozole, same 30% of people complain of joint pain. Vitamin A, which is isotretinoin, about 10% of people complain of pain. Carvedilol, which is a beta blocker, 5 to 10% of people complain of joint pain with that medication. Those medication, the steroid is very important to always ask. If you take steroid long-term for whatever reason, those can increase your risk of septic arthritis. So it's definitely a risk factor. It's important to be aware of that. Taking DOACs, anti-vitamin K, like our patient in that vignette, is obviously a high risk of developing hemarthrosis. So it's always important to be aware of that. Diuretics, pretty much all of them, chlorthalidone, hydrochlorothiazide, indapamide, metolazone, spironolactone, can increase the risk of gout. They usually increase the uric acid level and can actually cause gout. So all those are important to keep in mind, as they can increase the risk of joint pain. I didn't talk more about the past medical history of any autoimmune disease or the family history of any autoimmune disease, but it's pretty straightforward. If you have a family history of autoimmune disease, or if you have a personal history of lupus or RA, you have a higher chance of getting other autoimmune disease. So it should definitely be a question to ask if somebody comes from joint pain. History of gout. Gout, we talked about it earlier. There was new guidelines from the American College of Rheumatology in 2021. If we have a second gout flare-up in 1 year, we can start a low-dose allopurinol with anti-inflammatory therapy, whether it's colchicine or NSAID, without worsening the flare-up. So with the first gout flare-up, the shared decision-making is appropriate in patient at high risk. The trend before was always to say, if you have a flare, we cannot start allopurinol. Here, that's what they talk about here with the first good flare-up. There is a shared decision-making. Usually, if the uric acid is more than 9, if you have urolithiasis, or if you have stage 3 kidney disease, usually we won't make the decision. I'll probably let rheumatology decide that. But, starting allopurinol or medication as such is probably the right thing to do. And usually we want to look for uric level, urate level less than 6 milligrams per deciliter to decrease the flare-ups. Sexual history, probably a topic that can be sometimes a little difficult to talk about with our patients, but definitely helpful. Gonococcal arthritis is the most common type of non-traumatic acute monoarthritis in young sexual active people in the United States, 3 to 4 more common in women than in men. There is 2 types of those: localized septic arthritis, which is going to be a single joint, but there is also these particular patterns or syndrome, which is called arthritis dermatitis syndrome. On top of having some joint pain, they're going to have dermatitis. Those are tricky. It's usually, the history is helpful. If you have joint pain and you actually tap the joint, it's very common to actually to not find the gonococcal. So it can be very tricky, and it's a tough one to find. History of illegal drug use. The IV drug users are very high risk for septic arthritis. The most common one is a sternoclavicular joint. This is usually Staph aureus, MRSA, or Pseudomonas aeruginosa. Usually, this is conservative treatment with antibiotics. Can do a surgical drainage, and debridement has shown a pretty high failure rate. So if we see somebody in the office or in the ER or urgent care, if it's the sternoclavicular joint, they are not always IV drug user, but it's probably always a good idea to kind of dig into that a little further. Alcohol use is always a important thing to ask, and travel and tick bites as well. Lyme disease is not common in Texas. It's common in the north. There is always a few cases here and there. In the United States, it's usually a monoarthritis or oligoarthritis. That means it's usually a single joint or 1 or 2 joints. People that come sometimes, especially now with Google, I've had a lot of patients come and say, hey, I think I have Lyme disease. I read on it on the internet, especially since that case with Avril Lavigne. It looks like that was, I don't know, a lot of people came and thought they had the same thing. It's not people that have diffuse joint pain. It's usually 1 to 3 joints that are affected. It's chronic usually. People say they had pain for several months. And several weeks to several months, and they usually the tick itself needs to be attached usually for 36 to 48 hours. So people that goes in the woods and the bushes, or obviously it's always recommended to check their skin. Now, if the tick has just been attached for a couple of hours, it's very rare to transmit the disease. There is usually no fever. We can ask for an ELISA test. This detects the antibody itself. If it's positive, we have to ask for a Western blot test to confirm it. If we actually tap the joint or whatever joint is affected, and if we send it to culture, it's actually extremely difficult to culture the Borrelios. So it's usually best to ask for PCR. which it's actually probably the best test. The treatment is going to be doxy and amoxicillin for 30 days for that particular disease. So here are just a few etiology of joint pain. So if it's a non-inflammatory and it's a chronic, it's affecting several joints. Usually we think about osteoarthritis, traumatic osteoarthritis, meaning you've had a car accident before, whether it was broken or not, and then you start having spurs and change of the capsule. That can be painful, and that can cause non-inflammatory chronic polyarthritis. Hemochromatosis, as we talked about earlier, those are non-inflammatory. They can affect several joints, and they're usually painful over time. Amyloidosis, we didn't get too much into that. That's pretty rare, and I mean, those need a further, bigger workup, but they also start with usually non-traumatic chronic pain. If we have inflammatory and acute monoarthritis, this is that picture here on the right. It's usually one joint. Here is the knee. It's swollen. It's red. It's painful. That's the one we talked about earlier. The first thing to roll out is septic arthritis. The first thing to do is ask for fever, chills, probably do a blood test, and we have to tap the joint and send it for culture. This can also be gout or pseudogout. Gout is extremely painful. They usually have allodynia or hyperalgesia, which is basically extreme pain with even non-painful stimuli. It's, it can present that way also with an inflammatory acute monoarthritis. And you could also have systemic rheumatic disease manifesting as a monoarticular involvement. If we have inflammatory now, inflammatory process, which is chronic and one joint only is affected, we can think about a chronic infectious arthritis, as we talked about earlier, those indolent infectious arthritis. Sometimes they can take longer than usual to happen. Lyme disease is usually chronic. It's also usually inflammatory. As we talked about, it could be monoarthritis or a couple of joints. Crystalline synovitis, which is basically our gout, pseudogout, they can be painful also over time. Post-articular juvenile idiopathic arthritis, systemic rheumatic disease presenting with monoarticular involvement. Now, if it's inflammatory, again, but it's chronic polyarthritis, so several joints are affected in a chronic manner and it's inflammatory. This is when we start thinking about all those inflammatory autoimmune diseases. So rheumatoid arthritis, lupus, usually they say, oh, I have several joints that are painful. It's red, it's swollen, I'm very stiff in the morning, and it's been going on for several months. So that should kind of ring bells about potentially inflammatory autoimmune diseases. Spondyloarthropathies, we talked about psoriatic arthritis, reactive arthritis, ankylosing spondylitis, inflammatory bowel disease. The viral arthritis we talked about earlier, parvovirus B19 is a common one, especially in children. Those are usually the one that comes with slapped cheeks, it's called. But those also cause inflammatory type of pain over time, and it's usually several joints that are affected. Behçet disease, it's also a pretty rare autoimmune disease. Those are the ones that cause ulcers in the mouth, also in the genitals, some diffuse joint pain. It's pretty tough to diagnose, but those, if there is a suspicion of this, those should also probably be sent to the rheumatologist as well. What workup do we do for joint pain in general? Usually we do a CBC looking for, we look for high blood counts. We can also ask for a differential on those, which would tell us the amount of neutrophils. That can be extremely important. CMP, so it's going to be our sodium, potassium, and then we're going to have the renal panel and the hepatic panel, liver panel as well in there. ESR, CRP, I always ask those. Those are the inflammatory markers. That's going to help us if that's a septic arthritis, even if there is a gout or other inflammatory autoimmune diseases, those are going to be elevated. TSH, TSH, thyroid problems can cause all type of problems, including joint pain. So it's always good to include that in there. Uric acid, as we talked about earlier, if we think it's gout, uric acid is not always necessarily elevated in the gout setting. Now, especially people that we know they have gout, we want to bring that uric acid level lower. lower than 6 usually. CK, this is more a muscular marker, but again, a lot of people have a difficult time telling if it's a joint pain or a muscle pain. It's not wrong to ask for a CK. If it's extremely elevated, that's going to change the differential diagnosis to more of a muscular problem rather than a joint problem. Rheumatoid factor, if you think it's rheumatoid arthritis, is always helpful. ANA, which is part of the test that we order when we think it's an autoimmune disease. Plus minus, as we talked earlier, Lyme, ELISA here in Texas, probably not the most common things, but something to keep in mind if the patient has been traveling recently. Asking for a UA is helpful, and a chest X-ray as well. Again, for chest X-ray is more looking for unusual diseases, but probably something we won't order right away, but looking for sarcoidosis or autoimmune problems can also be seen on X-ray sometimes. And then plus minus joint aspiration. When we do a joint aspiration, we usually ask for a cell count. That's going to give us usually the WBC. That's the one we care about, as well as the neutrophil. Gram stain, if we think it's septic arthritis. Cultures, aerobes and anaerobes, and the crystals. So this is the analysis of the synovial fluid, looking for WBC count, neutrophil count, and so normal fluid could be from 0 to 200 per millimeter cube. Neutrophil count is usually less than 25%. If it's a septic joint, it's going to be extremely elevated WBC. And actually, from my experience and from talking about this with many physicians, obviously having an extremely high count is important, but the neutrophils are going to be the one that's going to probably give the answer. A lot of those diseases we talked about earlier, whether it's septic arthritis, gout, some autoimmune inflammatory diseases, can actually have an inflammatory count of like 30 or 30 to 50, sometimes over 50. But I've seen septic arthritis with less than 50,000, but with a neutrophil that were 92%. So that we still treated that one as, and it actually grew. It actually grew. Forgot the germ, but that was a septic arthritis. So I don't think the 50 has to be a cutoff. I think we have to take into consideration the WBC count, but also the neutrophil count. If it's 50,000, but it's 70, 75% of neutrophil, my guess is most people, especially in the hospital setting, would still receive antibiotics just to cover in case, but we still have to ask for crystals because those could definitely also be gout or other autoimmune diseases. I just put here a few x-rays in rheumatoid arthritis. The one on the left here, we can see that this is a fairly young woman. She has periarticular decrease, the mineralization of the bone is decreased in all her MCPs, basically, a little bit of the PIPs as well. This is, we can see this in people with RA. Obviously, some people would say osteoporosis. We don't really diagnose osteoporosis on X-ray, but there is definitely decreased mineralization in those periarticular regions. That one in the middle here, we can see an erosion and a little bit of a spur here on the MCP. So each time we see erosion, that can be coming from RA. So this is called the hitchhiker sign, which is basically that change in the IP joint of the thumb. We can also see here that there is a subluxation of the second and third MCP joint in the hands. So those are things to look up when we think about RA: erosion, subluxation of the MCPs, and that's a thumb sign here. When we talk about psoriatic arthritis, the X-rays are different than the one we had earlier. The RA, as we talked about earlier, they usually don't affect the DIP. So psoriasis arthritis does. So we can see here that there is severe changes of the DIP. They actually have some spurs, some growth, some bone growth present on the phalanges. Here we can see also some erosions and some pretty severe DIP changes. There can also be some new bone formation, as we can see here on that MCP of the thumb. There is bone formation, and usually when we have bone formation with erosion, it's a little more in favor of psoriatic arthritis. Here, they usually had that mouse appearance because of the erosion here and the bone growth. It has that like mouse appearance. That's about it for the presentation. Those are my references. So as a summary, I would just say that when we approach joint pain, always important to look at two things, ask questions, specific questions about the joint pain itself, everything we talked about when it started, how it started, is there any extra-articular involvement? And then also ask personal questions about the patient itself, not really related to the joint, but related to the individual, whether it's personal or family history of immune diseases, medication, any travel, the sexual history, is there alcohol, is there any drug use? And if we get all those information, putting it together, we can have a better idea of what's going on, order some good tests, additional testing, and refer if needed to a specialist with already a much better idea of what's happening in that person. I hope that was helpful. If you have any questions, don't hesitate to reach out to me. I didn't put my email there, but that can be easily found if you reach out to our department. And yeah, I hope that was helpful. Thank you everybody for listening.